Welcome to The Explainer. Today, we're literally putting on our medical detective hats. We've got a really fascinating clinical puzzle to solve, straight from a MedLearn case study. We're going to break down all the facts, examine the evidence, and see if we can crack this case together using only the clues provided. Okay, let's jump right in. I want to put you directly in the shoes of an attending physician. Imagine this. You're walking into the clinic, it's a busy day, and you're handed a chart for a 26-year-old guy dealing with chronic pain. The pressure is totally on, right? He's looking to you for answers. So the question is, can you navigate the clues, filter out the noise, and nail the right diagnosis? Let's find out. All right, let's meet patient case 01 and look at the initial presentation. So here's the deal. We have a cluster of 5 distinct, pretty distressing symptoms in this young guy. These are our initial forensic clues. We've got a 26-year-old dealing with chronic abdominal pain, noticeable weight loss, persistent diarrhea, and a low-grade fever. Now, think about how these symptoms interact with each other. That low-grade fever, that's a huge red flag that the body is fighting something off, maybe some kind of systemic inflammation. Then you add in the weight loss and diarrhea, which strongly suggest his GI tract just isn't absorbing nutrients the way it should. And of course, the chronic pain tells us this isn't just, a 24-hour stomach bug. There's something persistent, something structural going on here that we absolutely need to look closer at. Okay, let's move on to uncovering the clinical evidence. To get to the bottom of this, the investigation actually unfolds in 2 really critical steps. Step 1 is a colonoscopy. This gives us a direct camera view inside the colon, and right away we spot something highly specific. We're seeing skip lesions and ulcers located right in the terminal ileum, which, if you remember, is the very end of the small intestine. Step 2 is getting a biopsy, basically taking a tiny tissue sample from those inflamed areas. And wow, under the microscope, that biopsy reveals non-caseating granulomas. If you're wondering what those are, they're essentially these tiny nodular clusters of immune cells that form deep within the tissue. But crucially, they don't have that dead center you might see in other types of infections. Now, when we actually map these text clues onto the anatomy itself, it reveals the exact locations of all this damage. It's really something. Notice those bumpy skip lesions. They literally skip over healthy tissue. So the disease isn't continuous at all. It's just patching along the intestinal wall. Then, a bit lower down, you have these red, raw ulcers forming right on the surface. And looking at a cross-section, you can see exactly where those non-caseating granulomas are forming, bearing deep within the tissue. Seeing the pathology mapped out visually like this, well, it completely shifts how we understand the sheer severity of what this patient is going through. With all that evidence mapped out, it's time for the diagnostic lineup. All right, we've got 4 prime suspects for this intestinal damage. Suspect A is ulcerative colitis. Suspect B is intestinal tuberculosis. Suspect C, Crohn's disease. And finally, suspect D is irritable bowel syndrome, or IBS. Now, every single one of these can cause serious gastrointestinal distress. But our job as detectives here is to figure out which one perfectly aligns with those very specific skip lesions and granulomas we just identified. So what's the verdict? Which of these 4 diseases is the perfect match for our trail of biological clues? Let's do a quick recap. We've got a 26-year-old guy, involvement of the terminal ileum, those patchy skip lesions, deep ulcers, and of course, the non-caseating granulomas. Well, those classic hallmarks point directly to option C, Crohn's disease. Yep, it is the completely unique combination of the skip lesions and those granulomas that really gives it away. But before we wrap up, I want to leave you with one final provocative thought. Now that we've successfully diagnosed the disease, how would you go about designing a treatment plan to stop the body from creating these lesions in the first place? Because really, that is the true challenge that starts the exact second the diagnosis is made.